Hi, my name is Diana, and today I'll be presenting my concept map. My topic will be on congestive heart failure. My clinical date was January 30th. My patient was a 52-year-old male. He was a full code. He had no known drug allergies. His primary diagnosis was congestive heart failure with a STEMI. And some cultural considerations and social considerations are my patient was bilingual. He was Hispanic, Catholic. He suffered from substance abuse, and his sister was at his bedside. The pathophysiology of congestive heart failure with the STEMI. So with congestive heart failure, there has been an impairment to the ventricles from pumping arterial blood effectively to the rest of the body, which means that the heart is unable to meet the high demands of the body, which leads to decreased cardiac output. With decreased cardiac output, the patient may experience fluid overload, weight gain, decreased perfusion, especially to vital organs, shortness of breath, edema, tachycardia, weak peripheral pulses. The number one risk factor for congestive heart failure is hypertension. With a STEMI, there has been a complete blockage to the coronary artery. The coronary artery is a main artery that supplies the heart muscle, which then means that there has been a restriction of blood flowing into that area of the heart muscle, leads to decreased oxygenation, which leads to necrosis or cellular death of that area of the heart muscle. My patient's past medical history was he had a new onset of hypertension. He had an unhealing venous stasis ulcer in his left lower leg. He had rheumatoid arthritis. He was obese. He was pre-diabetic. He was a methamphetamine user, tobacco user. Calculated pack years were 12 and a half. He was an alcoholic, and he was homeless. He was living in a van. On January 29th, the patient presented to the emergency department with a new onset of hypertension, shortness of breath, but had no history of cardiac issues. His vital signs were blood pressure 208 over 108, pulse was 103, temperature was 98.3 degrees Fahrenheit, oxygen was 93% on room air, respirations were 20, admitting weight was 201.3 pounds, pain was 2 out of 10. He had some bronchi and crackles bilaterally in his lower lobes, and he had a non-healing left leg wound ulcer that he said had been going on for months. Upon my assessment on January 30th, some significant cues were his blood pressure, his oxygen, and his MAP. At 7:08, he had a blood pressure of 163 over 92. He was now on 2 liters of oxygen via nasal cannula, and he was at 90%. At 9:35, before I gave him his cardiac medication, he was at 185 over 98. He was still at 90%. A MAP was elevated. An hour after giving his cardiac medication, he was at 158 over 89. He was now at 93, and his MAP was going down. At 11:42, this was his best blood pressure. He was 148 over 83, 92%. MAP was also going down. By 1, he was up again at 172 over 88. He was now on 95%. MAP was going up now. By 3, he was at 160 over 83, 97%, and his MAP had started to go up again. Some significant cues upon my shift assessment were patient was on telemetry. He was reading normal sinus rhythm with some ST elevation. He had shortness of breath, dyspnea on exertion and at rest, which led him to be on 2 liters of oxygen via nasal cannula. He had periods of desaturation into the low 80s when he was sleeping. He still had mild crackles in the lower lobes bilaterally. His peripheral pulses were +1 bilaterally. Capillary refills were greater than 3 seconds bilaterally in the lower extremities. They were around 5 seconds. He had edema of +2 bilaterally in his ankle, leg, and foot on right and left side, and he still had his wound on his left lower leg, and then his lower extremities were red, dry, cracked, flaky, and cool to touch. Due to his recent admission, he only had one diagnostic test, which was an echocardiogram. It was done on January 30th at 8:30 a.m. His ejection fraction was still within range. They did find that he had a STEMI without any chest pain. His left ventricle wall was thickened. His left atria was moderately dilated, and the right ventricle was dilated with normal systolic function still. His abnormal and relevant lab values were his potassium was elevated, his alkaline phosphate levels were elevated, glucose was elevated, albumin was low, BNP was elevated, red blood cells, hematocrit, and hemoglobin were all low. White blood cells were within normal range. Troponin was elevated on both the 29th and the 30th, and his A1C was right in between pre-diabetic. My patient developed congestive heart failure due to the new onset of uncontrolled hypertension and shortness of breath. Upon reviewing his labs and diagnostic tests, he had elevated troponin, elevated BNP, elevated potassium, marked ST elevation. He had crackles and rhonchi in his lower lobes, edema in the lower extremities, weak peripheral pulses, and a non-healing venous stasis wound. My patient developed hypertension due to atherosclerosis in the blood vessels, making it harder for the heart to pump faster and harder to reach the rest of the body. He had a venous stasis wound due to decreased perfusion in the lower extremities caused by decreased cardiac output, elevated blood pressure of 208 over 108, and elevated pulse of 103 is due to the heart being overworked and due to thickened ventricles as well as his weight. Bronchi and crackles is due to the backup of fluid into the lungs due to the heart not pumping effectively. Elevated blood pressures on January 30th ranging from 185 to 148 systolic and 98 to 83 diastolic gives us a better picture of effective medication regimens and also indicates his uncontrolled hypertension. Shortness of breath, dyspnea, and periods of desaturation when sleeping is due to the heart unable to pump blood when it's laying down due to the blood backing up into the pulmonary circulation, causing that decrease in perfusion. He is on 2 liters of oxygen due to the heart having difficulty to pump blood towards the body due to the desaturation when sleeping. And then the bilateral lower extremities are weak at +1, capillary refills are 5 seconds, and edema bilaterally is due to decreased perfusion due to the reduced blood flow that causes poor circulation in the lower extremities since the heart is trying to perfuse vital organs. The skin is red, dry, cracked, flaky, and cool due to decreased perfusion in the lower extremities, and a cardiac restricted diet helps decrease blood pressure as well as help with his prediabetes and his obesity. The electrocardiogram showed that the left ventricle wall had some thickness, which indicates that the left ventricle can't eject the usual amount of blood volume to the rest of the body, and it also indicated a STEMI. Elevated potassium is due to tissue ischemia from myocardial heart damage. Elevated alkaline phosphate can possibly indicate fluid buildup in the liver. Low albumin is probably due to the unhealing venous stasis wound. High BNP can indicate heart failure. Low red blood cells, low hemoglobin, and low hematocrit all indicate anemia due to decreased cardiac output. High troponin indicates heart tissue necrosis or damage to the coronary artery, which is what supplies blood to the heart, and also from the ST elevation. High A1C and high glucose indicates prediabetes. And then obesity, patient weighed 201.3 pounds, indicates that the heart is being overworked. My priority nursing diagnosis is decreased cardiac output related to congestive heart failure with the STEMI, decreased peripheral pulses, and anemia as evidenced by, and these are all the cues I was able to come up with to help support my priority nursing diagnosis. My second nursing diagnosis is excessive fluid volume related to edema, rhonchi, crackles bilaterally in the lower bases as evidenced by, and these are the cues I was able to come up with to support my secondary nursing diagnosis. My third nursing diagnosis is ineffective health maintenance related to patient being homeless, lacking resources, suffering from substance abuse, as evidenced by, and these are the cues I was able to come up with to support my third nursing diagnosis. I chose decreased cardiac output as my priority nursing diagnosis due to the new onset of congestive heart failure, the uncontrolled hypertension, the shortness of breath, the decreased peripheral pulses, and the goal is to prevent further decrease in oxygen levels, controlling that blood pressure, and increasing perfusion to the rest of the body and especially to vital organs. So the goal is to prevent further stress on the heart. My second nursing diagnosis was excessive fluid volume. I chose this because my patient had bronchi and crackles in the lower lobes, which meant that fluid was now in his lungs due to excessive fluid volume. But my patient was already receiving diuretics. He was in strict intake and output. He excreted more than 500 milliliters at the end of my shift. And so I chose this because interventions were already being made to decrease fluid volume in the body. I chose ineffective health maintenance as my third nursing diagnosis because my patient was homeless, he lacked food and resources, and he suffered from substance abuse. That poor control of a new diagnosis can lead to worsening conditions, that can lead to decreased oxygenation to the body and to tissues, and that leads to decreased perfusion, and that can lead to worsening outcomes and even death. My goal for decreased cardiac output is by the end of my 9-hour shift, the patient will demonstrate improved signs of cardiac output by maintaining blood pressure below 180 systolic and below 90 diastolic. The patient will not experience any new or worsening pain, and peripheral pulses will be +2. My goal for excessive fluid volume is by the end of my 9-hour shift, the patient will demonstrate increase in urine output of greater than 50 milliliters per hour with daily weights. My third goal for ineffective health maintenance is by the end of my 9-hour shift, the patient will demonstrate an adherence to medication regimen consisting of cardiac medication, anticoagulants, and diuretics. Interventions for nursing diagnosis number 1. Obtain vital signs every 2 to 3 hours. Blood pressure, pulse, and oxygenation reflects the patient's cardiac output and perfusion. Assessing pain every 2 to 3 hours helps assess any worsening or improvement in patient's pain and status. Performing a shift assessment focusing on the heart, lungs, and lower extremities, peripheral pulses, temperature of the skin, and color, as well as capillary refills, help evaluate any worsening or improvement of perfusion of tissues and cardiac output. Administering medication, heparin 5,000 units, losartan 100 milligrams, spironolactone 25 milligrams, and metoprolol 25 milligrams, helps assess and reinforce a effective medication regimen. Heparin helps prevent clots and decreasing the chances of getting an MI. Losartan is an angiotensin receptor blocker, which helps relax blood vessels, which in turn lowers blood pressure and treats hypertension. Spironolactone is a potassium-sparing diuretic, which removes excessive fluid while not losing any potassium. Metoprolol is a beta blocker that decreases blood pressure and decreases cardiac workload and improves ejection fraction. It's also important to monitor labs daily for any changes in electrolytes, especially potassium, any worsening anemia, or troponin levels. Monitoring this helps show signs of improvement or worsening of heart failure, fluid and electrolytes due to fluid overload, and also assessing troponin levels. Intervention for my second nursing diagnosis is patient will have a continuous pulse oximeter. This helps us monitor more accurate oxygen saturations and allow us to document appropriately. Assessing the lungs, lower extremities, peripheral pulses, skin, and capillary refills allows us to monitor for fluid overload in the lungs, the lower extremities for any edema, and to assess perfusion. Strict intake and output allows us to monitor for fluid overload and the effectiveness of diuretics. Obtaining a daily weight helps us find any changes in edema and manage fluid retention. Administering spironolactone is a potassium-sparing diuretic, which removes excessive fluid while not losing any potassium. Monitoring CBC and CMP helps us see any changes in electrolytes, edema, and infection, and any worsening anemia. Interventions for my third nursing diagnosis. We will provide education on cardiac medication, anticoagulants, and diuretics. It's important to educate patients on any new medication they are receiving, the mechanism of action, why it's given, and common side effects. We will also provide education on signs and symptoms of a heart attack. It's important for patients to understand common signs and symptoms so they can report to us immediately. Evaluation of outcomes for our priority nursing diagnosis. For our first goal, our patient was able to meet it. His blood pressures were below 180 systolic and below 90 diastolic after his cardiac medications were given. His lowest blood pressure was 148/83. For our second goal, patient was also able to meet it. They did not experience any new signs of pain and especially no chest pain. Patient reported 0 out of 10 pain throughout my entire shift. For our third goal, he was not able to meet it. His peripheral pulses were still at +1 during my focus assessment. Evaluation of outcomes for our second nursing diagnosis. For our first goal, our patient was able to meet. He excreted urine of greater than 500 milliliters. He actually excreted 225 milliliters at the end of my shift. For his second goal, he was also able to meet. I obtained a daily weight, and patient had actually decreased weight of 2 pounds from his admission weight. Evaluation of outcomes for my third nursing diagnosis. Our patient was able to meet this goal. Patient was educated on the importance of keeping low blood pressure readings, the importance of preventing life-threatening blood clots, the importance of decreasing the fluid in his legs, as well as preventing fluid from entering his lungs. Patient took all his medication. Patient was asking questions and showing signs of understanding. Additional interventions. A cardiologist's consult is necessary due to the new diagnosis of congestive heart failure. It's important for patients to speak to a cardiologist to help individualize treatment plans for proper adherence to medication, and due to the lack of resources necessary to maintain an adequate quality of life. This is ongoing. A consult was made. Another intervention is a wound care consult. Due to the prolonged unhealed venous ulcer, a wound consult is necessary to create a proper diagnosis, find treatment plans, and help prevent further complications. Also, due to the lack of resources, a plan needs to be set for follow-up if wound care is needed. This is ongoing. A wound care consult was pending. Another intervention is a dietitian and nutritionist consult. This is necessary due to the new cardiac diet. He was pre-diabetic and he has poor access to healthy food. Patient needs to be educated on proper eating habits and nutrition choices, as well as help find food banks available in the area. This was undetermined if consult was made, but food choices were being monitored by staff and by hospital cafeteria. A polysomnography referral is necessary due to the risk factors of him being obese, had a smoking history, hypertension. He would desat into the low 80s and 85s. He would fall asleep while talking and snoring. All signs of obstructive sleep apnea, but this was undetermined if referral was made. This is my reference page, and thank you for listening.